Morena, I'm going to take you in a very quick overview of what a collaborative is. To start by saying, for us, this is an exciting day. What we're trying to do through a collaborative is generate a sense of community, really. And there's a whole lot of ways in which the methodology helps us do that. I want to just start by reminding you really in what a complex system we are all operating. This is an attempt to represent that. So that large circle in the middle is the program itself, the quality improvement program. And then if you look all around it, you'll see all the pieces that support the program or are relevant to the program. In the green, we have Consumer Advisory Group, the very importantly Maori Advisory Group, which have been established to support this program, a leadership group, a stakeholder group. That's all the framework that's been put in by the Commission around the program. Down in the left-hand corner, we have all the existing groups that some of you will be part of. Again, really key and influential, the GMs, the CDs, the Directors of Nursing. We've got quality improvement facilitators being trained and new cohorts being trained this year. We've got a quality improvement network system set up. Over on the right, we've got really important partnerships with LeVar, with the PO, with the National KPI program. We're very much building on that they've already started in seclusion, trying to accelerate that work. And then, of course, we have yourselves down in the right-hand corner, all the project teams coming together, as well as our international colleagues. So, for instance, our colleagues from Scotland who are lending us support and can provide us with some guidance in this work. I talked about community. Well, I guess another word that comes to mind is building a movement, if you like, and that's often used in relation to large-scale improvement change. The things about building a movement is that it is certainly important to communicate what the movement is about, but it's also as important, maybe more important, if you're going to really be effective, to communicate why you're doing what you're doing. And this slide references a man called Marshall Gans. So he talks about strategy, which is the stuff we do in our head, the what, but he also emphasises the narrative, the stuff that comes through our heart, which is the why. And Marshall, and if we can harness those things and bring people along together in both those ways, we end up with a shared understanding, which is the power behind a community movement. And if you're interested, I'd encourage you to Google Marshall Gans and just read a bit about his background. He's an academic at Harvard now, but he spent a lot of his working life with the union movements. And some of the ideas that he's worked with about public narrative and community organising were the ideas that were behind the successful campaign of President Barack Obama in that first campaign when they managed to mobilise a whole group of people who were not normally engaged in the political processes. So these are powerful ideas when they're done well. This is just a quick slide that outlines the methodology we're using here, and many of you have already seen a version of this. But essentially the blue boxes across the top are talking about the co-design training that many of you have been part of. That's been some face-to-face work, and then it's been work supported by WebEx processes. And we've now moved down with the pink arrow into the bottom piece of work here, which is the collaborative we're embarking on now. And this slide shows that again. David had a similar sort of slide. So we're moving from the co-design into the first learning session today. And through a series of 3 learning sessions with support between those learning sessions and work between those learning sessions, we'll test out a whole lot of ideas of change that we have, some of which have come from and evidence-based that we've assembled from literature, many of which will come from the ideas that we've generated from co-design, or an amalgam of the two. And we'll test them out and see if they work, and if they work, we'll continue with them or adapt them, and if they don't, we'll discard them. And at the end of that process, so the three learning sessions take us through about the next 6 months, we hope to be in a place where we have a set of initiatives or ideas that we can, that we know that are going to work, and that we can then begin to implement at scale. So, what are the advantages of national collaboratives? Well, it brings together subject matter expertise, lived experience, and quality improvement expertise. The whole thing works on the principles of a learning system, so feedback loops are really important in this. And essentially, this is the process that supports the how. So I talked earlier on about the what and the why and how important those were in mobilising people. This is what supports the how, the third part of that. It can be used at large scale, national programs, but it can also be used at much smaller scale in local programs such as 20,000 bed days, which was something that counties were involved with. And I guess how it works, the pace of the work, it's about agreeing aims and outcomes, and you've been doing some of that work already. It's about having a family of measures, and I know that there's been lots of discussion with you already about that, so outcome measures, the process measures, measuring what we're actually doing, but also the balancing measures to ensure that we're not ending up with things we don't want to happen. And as I said, testing ideas through rapid cycles of testing. And the structure to support the collaborative. This is you over here on the left-hand side of your screen, the DHB teams. And by DHB teams, we mean DHB communities, if you like. Not strictly organisationally speaking, because many of you don't actually work for the DHB, but DHB's communities. And then we've got all of the support at a national level in the middle there. Specifically over on the right, we've got the mental health improvement team from the Commission, and the leadership group, which are some of the people that you will know from your own organisations. But they come together in the middle with other really important component parts, like the Māori Advisory Group, like the Consumer Advisory Group, like our experts from colleagues from overseas, and as well people that we bring in as content experts from time to time. So some of the sorts of things that have been coming up are, for instance, already are around nicotine replacement therapy, how to manage methamphetamine intoxication. So we bring in content, extra content expertise as we need it. So the support that you can expect through the collaborative, as I say, there's those national resources, the learning sets themselves, help with the improvement methodology, help with identifying measures and using data for improvement, ongoing coaching and mentoring, and WebEx conference support between the learning sessions, as well as the content specialists I talked about, and some international help and guidance. Progress to date, you largely know this, but I think we've assembled the teams. Most of you have identified, or you've assembled the teams. Most of you have identified clinical leads. You've started to engage with your data or think about your data. You've started to think about change ideas. We're starting to do some DHB visits, which certainly we've found very helpful, and we would like to engage with all of you through this process by visits on the ground. What you can expect from today, I mean, there are general things there about building relationships, sharing stories, learning from each other, but I guess specifically at the bottom of the slide there, work around your aims statement, the idea of that being SMART in the specific, measurable, achievable, relevant, and having some kind of time dimension to it. Some more discussion around the scope of your projects, about measures and the data collection, and then an introduction for some of you, I imagine, a first introduction to the idea of driver diagrams. PDSAs are probably more familiar to you. So a lot to get through, as was said, in one day. So just to finish, this is our aim, to minimise restrictive care, specifically to eliminate seclusion in all inpatient units by 2020. We know that's ambitious. We thought about whether to set zero seclusion as our goal or not, and decided on the basis of feedback from our communities that we should, and I think we've done exactly the right thing. We need to be ambitious. So encourage you to think about why zero seclusion is important. Each of you will have different stories, I imagine, as to why you believe it is important. I was thinking about some of those for myself, and some of the harm that I've observed from seclusion for people who've been put in seclusion over the years that I've been in practice, but also some of the, increasingly I think, a realisation of some of the harm that it does to the people who are, if you like, implementing the seclusion for staff as well.